All right, everyone. So today we're doing sport and exercise in adulthood. We're going to look at aging and the aging process, and then look at some of the physical activity trends throughout adulthood. We'll start off looking at that 18 to 64-year-old age range, and then moving into older adults at 65 and above. And then we'll move on to the last couple of pathways in our conceptual model of physical activity and health. It's pathway E and pathway F. So the first part of this lecture is on aging, and that's where most of our focus is going to be on today. So even though we're doing adulthood, the main focus of this lecture is going to be on that older adulthood time period. So if we have a look at the proportion of the population currently aged 60 years or older, well, this was in 2015, you can see there's a heat map of the world there, and the darker the color of red means the more people there are aged over 60. So in 2015, there was only one country where the proportion of individuals aged over 60 years exceeded 30%, and that was in Japan. So you can see there Japan's the darkest color red, and everywhere else is pretty light. In Australia, we're between 20 to 24%. Now, if we have a look at some predictions of what this map would look like in 2050, so not too long away. Now, in 2050, many countries will have a very similar proportion of older people as that of Japan did in 2015. So the main countries with that aging population are around Europe and North America, also places like Chile and China. And Australia there would have moved up one shade darker into that 25 to 29% range. So why is this happening? Why are our populations aging? Now, there's two key drivers of population aging: increasing life expectancy and decreasing fertility rates. So if we have a look at increasing life expectancy first, on average, people around the world are just living longer. Now, a small part of this increase is due to the improved survival of people at older ages. So now, more than we ever were in the past, we're better able to look after old, sick people and extend their life. However, most of this increase in life expectancy reflects improved survival at younger ages. So babies are living through childhood more so now than ever. And we can see in these figures, they show the trends for high income and low income countries. So you can see the top picture reflects trends in high income countries, and the bottom pictures reflect lower income countries. Now, the graphs on the right-hand side show the ages at which death occurs in low and high-income countries. And you can see how strongly a country's level of socioeconomic development is associated with mortality patterns across the lifespan. So in the lower income countries, death occurs most commonly in early childhood, and then the deaths are evenly spread across the rest of life. As countries develop, there's better public health. That means more people survive childhood, and the pattern of death changes into one where people are more likely to die as adults. And we can see in the high-income countries, most people are dying above that 70-year-old age range. So overall, with the significant advancements that we've seen in healthcare and socioeconomics in the past 50 or so years, more people are living past childhood and thus into older age, therefore increasing the life expectancy of the population. Now, the second reason that populations are aging is because of falling fertility rates. So parents in today's society now realize that their children are more likely to survive childhood compared to the trends that we saw in the past. So no longer are people like we'll have 6 kids in the hopes that 3 of them make it past childhood. So we know that they're going to survive, so we're not going to have heaps of kids in the hopes that, knowing that, 1 or 2 might not make it past childhood. So there's also an increased access to contraception today. We've got things like the pill and condoms, so there are far less unexpected pregnancies. In today's society, there's also quite a big change in gender norms and the acceptance of different sexual identities. So collectively, these factors have resulted in a dramatic decline in fertility rates. Historically, in many parts of the world, fertility rates range from around 5 to 7 births per woman. However, like we saw previously, many of these children didn't survive into adulthood. Now, the current fertility rate sits at around 1.4 to 1.9 children per woman in high-income countries. The exception to this fall in fertility rates is in Africa, where the fertility rate remains at more than 4 births per woman. Additionally, in this decreasing fertility rates, in many high-income countries, there was a big population bulge that occurred after the Second World War. You guys would have heard this being referred to as the baby boomers. So lots of kids, lots of babies in that time period, born in that short time period. And as the members of this population bulge, the members of these baby boomers, move into older age, the population aging is going to be temporarily accelerated as this big bulge moves through. So 2 contributors to population aging. Now, throughout the semester, we've talked quite a bit about the changes in our physiological and psychological systems that occur as we age. And there's actually a really big overlap between the changes that occur with aging and the changes that occur with disuse of our physiological systems. So the effects of aging and disuse impact a wide range of organ systems and functional capacities that can have pretty significant effects on health status in older adults. Now, some of the most notable changes common to disuse and aging include the following. So we've got a decrease in muscular strength and power, decreased aerobic capacity and cardiovascular function. There's a stiffening of the artery walls due to the loss of elasticity that occurs with aging, and this can result in things like hypertension and atherosclerosis. We have a decline in our functional abilities and movements like balance and gait. We also see things like reduced insulin sensitivity. So our insulin becomes less able to lower the level of glucose in our blood, and this can be a precursor to diabetes. We see an increased amount of visceral fat and total body fat. There's impaired immunity. So the function of our T cells, which are like our immune cells, reduces with age, which causes part of the immune system to weaken and increases the risk of becoming ill. We also see a weakening and a thinning of our cartilage and our tendons, as well as a significant decrease in bone mass. Now, the most problematic expression of population aging is the prevalence of frailty. So you've probably seen the word frail used to describe someone who's weak. Like I might say that my grandma's very frail. But frailty is an actual clinical condition that's defined as a state of increased vulnerability resulting from an age-associated decline in function, such as the ability to cope with everyday or acute stresses. So our ability to cope with stress is compromised. Now, to put that more simply, frailty develops as a consequence of age-related decline in our physiological systems. So frailty, it's a common clinical syndrome in older adults. It's been estimated that somewhere between a quarter to half of people older than 85 have frailty. And this condition carries a really increased risk of some poor health outcomes, things like falls, delirium. Delirium is a serious disturbance in mental ability. So typically it would present as confusion or reduced awareness of your surroundings. Frailty also increases the risk of disability, hospitalization, and mortality, which is death. So in 2001, a frailty model was established with 5 variables. unintentional weight loss, self-reported exhaustion, low energy expenditure, slow gait speed, and weak grip strength. So those with 3 or more of the 5 factors were judged to be frail. Those with 1 or 2 of the factors were pre-frail, and those with none of the factors are considered to be robust elderly people. So there's some important guidelines regarding each of these factors. With weight loss, it's got to be a 4.5 kilo weight loss per year, or a 5% of your body weight loss per year. In exhaustion, you take a survey which asks you lots of questions, and if your results come up as you said you were exhausted, and you have that 3 to 4 days per week, you would be positive in that aspect. For low energy expenditure, it's less than 383 calories per week for men, or 270 calories per week for women. Slow gait speed is basically where they get you to walk a certain distance. So in this case, it would be 4.57 meters. And time, how long it takes for you to walk that distance. And then depending on your gender and your height, they would give you a score, whether that's a good or a bad score. Weak grip strength is also the same as well. It's stratified by sex and body mass index. So stratified just means grouped by. So depending on your grip strength, if you're a woman or a man, is going to be different. If your body mass index is overweight or underweight, a good score is going to be different. So if you meet 3 or more of these 5 factors, your risk of disability, hospitalization, and falls increases significantly, which is not a very good outcome, because in a 2000 study, it was found that 80% of elderly women would rather be dead than experience the loss of independence or quality of life that results from something like a hip fracture and a subsequent admission to a nursing home. So how can we avoid this and increase our chances of successful aging? Now, successful aging, it includes 3 main components: low probability of disease and disability, high functional capacity, and active engagement with life. Now, importantly, successful aging, it's more than just the absence of disease or the maintenance of functional capacity. Both of these are really important components of aging well, but it's their combination with this active engagement in life that fully represents this concept of successful aging. So, each of these 3 components of successful aging includes some subparts. The low probability of disease refers not only to absence or presence of disease, but also to the absence or presence of risk factors for disease. High functional level includes both physical and cognitive components. So you need to have capacity in both physical and cognitive aspects of life. And the active engagement in life takes many forms. Mainly, it includes our interpersonal relationships with family and friends. And active engagement also includes productive activity. So productive activity is where it creates, is an activity that creates societal value. Things like working or volunteering or caring for another person are productive activities. So let's have a quick look at some examples of people who you would probably say have successfully aged and what they attribute to their success in old age. So many people would consider Warren Buffett to be a very successful professional. At 90 years old, he's a billionaire philanthropist with no plans to retire, and he says he still loves his work. So he's clearly successful professionally and apparently very happy as well. So is he a model of successful aging? What are some of the secrets to successful aging for Warren Buffett? Well, he's an avid Coca-Cola drinker. Reportedly, he drinks 5 cans of Coke a day, and he's previously said that he's about 1/4 Coca-Cola. So, of course, Warren Buffett's soft drinking habits may not be the path to successful aging for most of us, but he's identified another key factor that he attributes to his success, and that is reading. So he typically spends 80% of his day reading, and he thinks that is why he's still going so strong at 90 years old. Conspiracy theorists probably wouldn't agree. They'd probably say that he's some sort of reptilian. Let's have a look at another example now. So what about Jeanne Calment from France? She was born in 1875 and has the longest confirmed human lifespan on record. So she lived to the age of 122. Now, she said her longevity could be attributed to a diet rich in olive oil, but also to drinking port wine and eating large amounts of chocolate, and of course, smoking a few cigarettes a day since she was 20 years old. She's also stated that being calm allowed her to age well. So she reportedly remained mentally sharp until she died in 1997 at 122 years old. She outlived her daughter and her grandson by several decades. So from these two examples, we can assume that genetic factors play a pretty huge role in successful aging, because we know that smoking and excessive soft drink intake is not going to be that good for us. So it's always a combination of genetic and environmental factors. Now, these two examples are really anomalies. So let's have a look now at what does the average regular old person look like. So here's the typical history of an elderly person that we would see. Ray Moon, he's 84 years old with a pretty big list of previous diseases. So he's a former heavy smoker and drinker. He's had 2 strokes. He's had a heart valve replacement, which is a big major open heart surgery. He's had a heart attack and now has a pacemaker. So a previous heart attack and now he's got a pacemaker. He was diagnosed with depression and also bladder cancer. So if you try to picture Ray Moon, I'm going to assume that you would all think that he looks something like this. Now, this is not Ray Moon. Ray was actually the world's oldest competitive bodybuilder. He was from the Gold Coast and was competing in bodybuilding until 86 years old. Now, sadly, he passed away earlier this year at 90 years old after losing his battle with bladder cancer. We saw in his history that he used to be a heavy smoker and drinker and didn't really care about his health and fitness. Now, in his 70s, he began going to the gym as a way to deal with his clinical depression, and he was approached by a gym manager to try competitive bodybuilding. So he would train 2 hours per day, 5 days a week, doing several different types of resistance training workouts. So someone with many chronic illnesses, you'd be hard-pressed to say that he had successfully aged. But in fact, his muscular strength and his body composition was comparable to men much, much younger than him. He was still able to do something even with all those chronic health conditions. And those of you who are up on your anatomy would know that there isn't a new muscle, that's actually his pacemaker. So how does exercise optimize aging? Now, the rationale for the use of exercise to optimize aging can be divided into 5 broad topics. Regular participation in physical activity or planned exercise has been shown to minimize the physiological decline associated with aging. It contributes to psychological health and well-being. It increases our longevity and reduces the risk of and acts as a treatment for chronic illnesses, for many common chronic illnesses. So exercise has both a preventative and a treatment effect for several chronic diseases. And finally, exercise assists in the prevention and treatment of disability. So overall, substantial increases in the proportion of older people in our society is due to increases in life expectancy and decreases in fertility rates. With the aging population, we will see an increase in frailty in soon years, which will contribute to poor health outcomes in older adults. This is likely going to pose a pretty significant challenge for health and medical experts in the near future. Successful aging is multidimensional, including the avoidance of disease, the maintenance of high physical and cognitive function, and sustained engagement in social and productive activities. And overall, successful aging is influenced by both genetic and environmental factors. All right, now let's have a look at the trends in physical activity and exercise participation for Australian adults aged 18 to 64. Now, for adults, doing even a small amount of physical activity is better than doing none at all, due to the positive benefits associated with physical activity, the reduction of things like risk of disease and chronic diseases, which is something that we'll look at more closely later. Incidental activities such as commuting to and from work, for example, walking or cycling to work, are also associated with similar health risk reductions. So physical activity in adulthood doesn't necessarily have to be planned and structured activity. It can also be incidental. So for adults aged 18 to 64, the recommendations are presented again here. These adults should accumulate 150 to 300 minutes of moderate intensity physical activity, or 75 to 100 minutes of vigorous intensity physical activity. So summed up briefly in the table, it's 150 minutes of moderate to vigorous activity over 5 sessions per week. The recommendation is to be active on most, preferably all days a week, and do muscle strengthening activities on at least 2 days each week. Now, in terms of sedentary behavior, the recommendations are to minimize the amount of time spent in prolonged sitting and to break up long periods of sitting as often as possible. The Australian Institute of Health and Welfare also advocates that doing any physical activity is better than none. So if you currently do no activity, start by doing some, even if it's less than the 150 minutes per week, and gradually build up to the recommended minimal amount. Now, in the Australian Health and Welfare report, around half of adults, so 48% of adults aged 18 to 64, met the physical activity guidelines and were considered to be sufficiently active. Now, in general, as age increased, the proportion of people who were sufficiently active decreased. So you can see in the figure in this slide that the percent of people meeting the guidelines declines slightly across the adult lifespan. Around 1/4 of adults aged 18 to 64 met the strength-based activity guideline, which involves completing at least 2 days of strength-based activities per week. Across the age groups, adults aged 18 to 24 were most likely to meet this recommendation, so around 30%, and the proportion decreased steadily as age increased. So with 19% of adults aged 55 to 64 completing strength-based activities on at least 2 days per week. Overall, slightly more men than women met the strength-based activity guideline. And for both men and women, the proportion meeting this guideline decreased with age. Now, the decline was far more pronounced in men than it was in women. And you can see in this figure that across the age groups, the number of men meeting the guidelines declines dramatically from the 25 to 34 age group to the 35 to 44 age group, whilst the number of women meeting the guidelines across adulthood remains a little bit more stable, whilst it still does decline slightly. Overall, adults spent on average 4 hours and 29 minutes sitting at leisure on a usual weekday. So, leisure sitting doesn't include sitting at work, so this is outside of work time. Now, the following sedentary activities were some of the most common among adults. It included time spent watching TV, using the computer before or after work, reading, and sitting down for meals. If we have a look at what does happen at the workplace, so this is outside of leisure time, this is now work time. Of employed adults in Australia, around 44% spend most of their working day sitting. So this is like your office workers, your corporate workers. 21% report mostly standing, so hairdressers or chefs. And 19% report mostly walking for work. So waitressing, retail workers, nurses, and people working in hospitals. And then 15% report heavy labor or physically demanding work. This could be like your tradies, even some physiotherapists could fit into this group. Now, historically, reports of physical activity among adults have just taken into account the physical activity guideline, the 150 minutes of physical activity. But we know now that completing a certain amount of strength-based activity per week is a really integral component of the guidelines. Now, about 1 in 5 adults met both the physical activity and strength-based activity guidelines, so 19%. And this proportion, it's largely driven by the fact that nearly 70% of adults complete no strength-based activities on any days. So the reason why that proportion is so low, it's not due to the low number of people doing physical activity, it's mainly due to the low number of people doing any strength-based activity. If we have a look at some of the trends here, the average amount of physical activity that was undertaken for fitness, recreation, sport, or transport by adults was around 39 minutes per day. So on average, adults spend about 39 minutes per day doing physical activity. This includes vigorous as well as moderate physical activity, and also includes walking. So whether that's walking for fitness or walking to get to and from work. So on average, adults spend about 7 minutes per day on vigorous activities, 7.6 minutes per day on moderate activities, and then 24 minutes per day walking, whether that's for exercise or transport. If we look at this comparison between men and women, we see that on average, men spend more total time doing physical activity each day compared to women. Men also spend more time per day doing moderate and vigorous physical activity compared with women of the same age. So we can see there's a larger middle blue color and a larger dark blue color, signifying vigorous and moderate activity. The average time spent walking for exercise or transport, so now looking at the lightest blue color, was similar between men and women at about 25 minutes per day for men and 24 minutes per day for women. In the Australian Institute of Health and Welfare report, moderate physical activity was defined as a level that causes the heart to beat faster and some shortness of breath, but during which a person can still talk comfortably. And vigorous physical activity was defined as a level that causes the heart to beat a lot faster and shortness of breath that makes talking difficult between breathing. If we have a look at the most common sports and activities among this age group, the top 3 most common were recreational walking at 41%, fitness or gym activities at 36%, and then running or jogging at 18%. Now, additionally, the report found that around 16% of adults walked for transport as their only form of physical activity. Now, the main barrier to participating in sport or other non-sporting physical activities was not enough time or too many other commitments. Among those aged older, so 45 to 64, poor health or injury was also reported as one of the top barriers to participation. And around 13% of adults reported having a very physical job as their top barrier that prevented participation. I asked you guys a similar question back in week 1. What's the main barrier to participating in exercise activities for Australian adults? Most of you got that one right. 57% of you said not enough time, which would be the correct answer. And only a couple said poor health or injury. Now, this would be a more prevalent barrier when we're looking at those older age ranges. If we look at the motivating factors for participating in sport among adults, the top ones were for health, for physical health or fitness, which was 80% of the reason why people participated in physical activity, fun and enjoyment, and then social reasons down the bottom. So overall, we've seen that around 19% of adults meet both the physical activity and strength-based activity guidelines, and the adherence to these guidelines decreases with age. The most common activity in adulthood was walking, and the most reported barrier to participation in exercise or physical activity is not having enough time. Okay, moving on to part 3. Now, for Australians aged 65 and over, physical activity becomes really important to maintain our energy levels, increasing joint movement, preventing and managing mental health problems, and improving mood and memory function. So let's now have a look at the trends in physical activity and exercise participation for Australian adults aged 65 and over. So here are the guidelines from the Australian Institute of Health and Welfare. Older people are told that they should do some form of physical activity no matter what their age, weight, health problems, or abilities. They're told to be active every day if they can and in as many ways as possible. So they should do a range of physical activities that incorporate things like aerobic fitness, strength, balance, and flexibility. Older people should aim to accumulate at least 30 minutes of moderate intensity physical activity on most, preferably all days. And for those aged 65 and over who have stopped engaging in physical activity or who are new to physical activity, they should start at a level that's easily manageable for them and then gradually build up to the recommended amount. Older people who have continued to enjoy a lifetime of vigorous physical activity, someone who's maintained their sport and exercise behaviors throughout their whole life, should carry on doing so even at 65 years and older, just in a manner that's suitable to their capability into those later life stages. So if we look at the adherence to the physical activity guidelines, the report found that 1/4 of adults aged 65 and over met the physical activity guidelines of 30 minutes of physical activity on 5 or more days per week. Only 15% did physical activity on all 7 days, so quite a smaller proportion meeting those guidelines on every day of the week. If we have a look at the strength-based guidelines, the majority of people aged 65 and over, so 84%, completed no strength-based activities at all, and only 13% met the strength-based activity guideline. So there was a very small proportion, just 3.7% of elderly adults who incorporated strength-based activities on all 7 days of the week. If we have a look at the time spent during sedentary time. Obviously, in this age range, we've got people who are retired now as well. So those 65 and older who are employed spent about 4 hours and 57 minutes sitting at leisure per day. And then the non-working older adults, so they do not have a job to go to, they're going to obviously spend more time sitting at leisure because they just have more leisure time throughout the day. And on average, they were spending around 6 hours and 11 minutes sitting at leisure. And these findings were very similar between men and women. So there was no difference between the time spent in sedentary activities between those genders. And if we have a look at the average time between some age groups here, we've got 65 to 74, 75 to 84, and then 85 plus. And you can see that the time spent in leisure, in sedentary leisure time increases slightly as age increases. Now, the proportion of men and women aged 65 and over who met the physical activity guidelines was similar. So 27% for men and 23% for women. However, with increasing age, the proportion meeting the physical activity guideline among men remained the same, while for women, the proportion decreased. So if we look at the first half of this figure, you can see that the dark blue columns for men remain pretty stable throughout that older adulthood period, whereas the light blue columns for women decline dramatically from that 65 to 74 age range compared to the 85 plus age range. For strength-based activity, 16% of women aged 65 to 74 met the guidelines, compared with 8.1% of women aged 85 and over. So another decline for the women in the strength-based activity guidelines, whereas this decrease was not seen in men, where the proportion of individuals completing at least 2 days of strength-based activities remained relatively similar across all age groups. So overall, the findings are that around 6.5% of those aged 65 and over met both physical activity and strength-based activity guidelines. So only 1 in 10 people doing 30 minutes of physical activity 5 days per week, and at least 2 days of strength-based activities per week. If we have a look at the trend in the time spent on different physical activities, we see that overall there was about 29 minutes spent per day on physical activity, and that was broken down into 6.4 minutes on moderate physical activity, 1.4 minutes per day in vigorous physical activity, and 21 minutes per day for walking for either exercise or transport. Now, the average amount of physical activity that was undertaken among men was 33 minutes per day, which was higher than it was for women, who were sitting at 25 minutes per day. So you can see there the men beating out the women in the time spent during physical activity. Men and women aged 65 and over spent similar amounts of time doing moderate and vigorous physical activity. However, the men spent a much greater amount of time walking for exercise and transport compared with women of the same age group. So 24 minutes spent walking for men and 18 minutes spent walking for women. Some of the most common sporting and non-sporting activities undertaken for adults aged 65 and over include walking, again at 62%, fitness and gym activities still up there at 26%. We see swimming come in at 12%. Swimming is a very attractive form of exercise for elderly people because of the low impact it has. So a lot of elderly people, they've got arthritis or soreness in their joints, and with swimming we take out that weight bearing and it becomes a lot more enjoyable for them than going for a run or something. And then also golf in there at 10%. Some of the barriers to participation, we see poor health or injury really take out that number one spot there in those elderly age groups. So 48% of people saying it's their health or an injury that's keeping them from exercising. 18% say they're just too old. and then 11% saying not enough time or disability. Some of the motivators to participation, so why they're participating in exercise, is for physical health or fitness, for fun and enjoyment, and then social reasons coming in at 27% there. So what we've seen overall is that very few adults, only 6.5% of those aged 65 and over, meet both the physical activity and strength-based activity guidelines. And the adherence to these guidelines remains stable in older men, whereas the adherence to these guidelines decreases with age in older women. The most common activity in older adulthood, again, is walking, and the most common barrier to participation is poor health or injury. Okay, so now that we've covered the background of aging and gone over the guidelines and the trends in physical activity for adults, we're now on to pathway E of the conceptual model of how physical activity across the lifespan is beneficial to health. So pathway E demonstrates the influence of physical activity during adulthood on morbidity during adulthood. So in this part of the lecture, we'll discuss how physical activity in adulthood can prevent or treat chronic diseases. We now know that physical activity can prevent or improve many health risk factors and chronic diseases, things like hypertension, high blood cholesterol, diabetes, and cardiovascular disease. But research has also indicated that even small amounts of physical activity participation in the elderly can substantially decrease their risk of developing a chronic disease when compared with being physically inactive. So we know that older people are less active than young people. Even if they have the same daily physical activity volume, the physical activity intensity performed by the elderly person is always going to be lower than the intensity of activity performed by younger adults. This has important implications for the aging process because the decline of many physiological variables with advancing age and the incidence of chronic diseases are increased with lower levels of physical activity. For example, the risk of developing and consequently dying from a chronic disease like cardiovascular disease, type 2 diabetes, obesity, or cancer is lower in individuals with a higher physical fitness or greater daily physical activity levels. And this figure represents the manner in which exercise or physical activity may influence the disease incidence or prevalence in this population. So how, in fact, can physical activity prevent or help treat diseases throughout the lifespan? So exercise optimizes physical fitness and body composition. It also counteracts the age-associated changes in physiology. It can decrease the symptoms of disuse. It improves psychological profiles like symptoms of depression. And it also addresses many of the risk factors for chronic disease. So exercise has a therapeutic effect on many chronic diseases, some of which are mentioned here: obesity, diabetes, coronary heart disease, Parkinson's, cancer, arthritis, hypertension. The list goes on and on and on. If we have a closer look at obesity first, though, decreases in total fat mass and visceral fat mass are achievable by aerobic or resistance training. However, significant changes in total body fat are usually only seen in conjunction with an energy-restricted diet or really high volumes of energy expenditure and exercise. So to lose a significant amount of weight through exercise alone, you'd be looking at somewhere between 5 to 7 hours per week of really high intensity activity. Now, preferential visceral fat mobilization is often seen in response to exercise and dietary interventions, which means that small amounts of fat loss may be associated with substantial changes in visceral fat. So as an example, let's say we lost 5% of our fat. That might actually be associated with a 20% visceral fat loss. So the decrease in visceral fat, it's both protective and therapeutic for many chronic diseases and conditions. Now, although just generalized obesity is associated with many negative health outcomes, it's predominantly this excess in the visceral fat that's associated with insulin resistance, type 2 diabetes, hypertension, dyslipidemia, systemic inflammation, stroke, coronary heart disease, and many, many more. Now, one of the earliest studies that actually linked physical activity with coronary heart disease, which is one of the leading causes of death in the world, was done on London bus workers, so back in 1966. The researchers of this study reported differences in coronary heart disease rates experienced by London bus drivers. The bus drivers had high rates of coronary heart disease compared to the ticket takers on the bus who had low rates of coronary heart disease. Now, the drivers sat down all day driving their bus around town, whereas the ticket takers had to climb up and down the stairs and walk along these double-decker buses, collecting tickets and fares. And these results overall suggest an association between physical activity and coronary heart disease rates. Now, more recently, with advancements in research, it's been concluded that the risk of coronary heart disease due to physical inactivity is about twice as high among sedentary individuals as it is among active peers. Now, the association is between coronary heart disease and physical inactivity is equivalent in strength to the association between coronary heart disease and smoking. So if physical inactivity is just as bad as smoking in the development of coronary heart disease. Now, the population attributable risk of coronary heart disease due to inactivity is 35%. Population attributable risk is a really important public health measure because it's a calculation that takes into account the strength of the relationship between a risk factor, which is inactivity, and the health outcome, which is coronary heart disease. And it also takes into account the prevalence of this risk factor in the population. So how prevalent is inactivity in the population? So previous estimates of the population attributable risk of coronary heart disease have ranged from anywhere between 23 to 46%, but the best estimate is around 35%. So what this number means is that if all sedentary individuals could achieve at least a moderate level of physical activity, the coronary heart disease events in the entire population would theoretically decrease by 35%. If we have a look at type 2 diabetes now, prevention of type 2 diabetes is a major public health challenge because it has such a large effect on overall health. In a really large-scale study undertaken by the Diabetes Prevention Program Research Group, the authors investigated the preventative effect of lifestyle changes, metformin, or a placebo drug in high-risk adults. So what happened in this study was the researchers randomly assigned participants into one of three groups. The first group received an intensive lifestyle intervention which aimed to help them achieve and maintain a 7% weight loss and 150 minutes or more of physical activity per week. The next group received the drug metformin, which is a drug used to control blood glucose levels. It's primarily used in the treatment and prevention of type 2 diabetes. And then the final group received a placebo drug. So they just took a bunch of fake pills that did nothing, but they probably thought that they were getting the metformin pills. So this figure here shows the cumulative frequency of diabetes since the beginning of the trial. And what the researchers found was that in high-risk participants over the age of 60, diabetes incidence was reduced by 49% in the lifestyle group compared to the metformin or the placebo group. So just by maintaining that 7% weight loss and doing 150 minutes or more physical activity per week, there was a 59% reduction in the incidence of diabetes. So in these elderly high-risk populations, the drug metformin had no significant effect. They might as well have just been taking the placebo drug. So overall, these results suggest that lifestyle interventions, including weight loss and physical activity, have the greatest effect on the prevention of diabetes. So in this case, we see that exercise works better than the drug that would normally be prescribed. Now, insulin resistance is when the cells in your muscles, fat, and liver don't respond well to insulin and can't easily uptake the glucose from your blood. So glucose can't enter the cells as easily, so it builds up in the blood and your pancreas has to work harder, and this can eventually lead to type 2 diabetes. So the question is, does exercise have an effect on insulin resistance? Now, a group of obese older adults performed aerobic exercise for 5 hours per week at 85% of their maximal heart rate. So this equated to 5 1-hour sessions per week. They didn't just do 5 hours straight. So what they found was that after 12 weeks, there was a significant decrease in visceral fat, approximately a 20% decrease in visceral fat loss. And the decline in subcutaneous fat was far less, at around 10%. So the researchers reported that the loss of abdominal visceral fat through exercise correlated with improved glucose control and insulin sensitivity. And this indicated that insulin resistance can actually be reversed when visceral fat is decreased. So the improvement in physical fitness, glucose tolerance, and body composition in these participants reduced the risk of developing type 2 diabetes, and this was an at-risk population in the obese older adults. So exercise or drugs, which one is better? Here we're looking at the prevention of age-related changes in physiology and function. So does exercise or a drug work better to prevent these age-related changes? In terms of balance impairment, there's no drug that you can take to help prevent balance impairment. There's no drug that you can take, no legal drug that you can take to help prevent the decline in aerobic capacity. Exercise does all of these though. So exercise can help prevent all of these declines in physiology and function, whereas there's only a drug to prevent endothelial dysfunction. So this is when your arteries become stiffened. You can take calcium channel blockers to help relax and widen the blood vessels, but exercise has got the same effect. Insulin resistance, there's a drug we saw before, metformin, but in that obese age group of over 60 years old, exercise worked better than metformin in the prevention of diabetes or insulin resistance. For osteoporosis, we can also take a drug. We can take biphosphonates, and they inhibit the function of our osteoclasts. So we know that our osteoclasts are the cells that destroy bone, and by taking this drug, we can actually inhibit their function. So no longer do they destroy bone. If we look at the prevention of risk factors for chronic disease, exercise can help prevent the development of all of these risk factors. It can help prevent depression, hypertension, insomnia, systemic inflammation, cognitive dysfunction. There's a drug we saw, metformin, can help with insulin resistance, but exercise does it as well. So if you want to aid the prevention of these different risk factors, you definitely want to be exercising, because there's no drug that you can take to help prevent. You can take a drug to treat depression or treat hypertension, but you can't take a drug to help prevent it. If we look at treatment now though, so this is whether exercise or drugs can treat these chronic diseases, we see the drugs here really coming into play. So in terms of arthritis, atherosclerosis, cancer, chronic heart failure, frailty, hypertension, exercise can help treat all of these conditions. It's very good in treating arthritis and depression or anxiety especially, and stroke as well. However, there are drugs that can be taken for each of these apart from dementia and frailty. So there's a treatment drug that often works well. So it's clear that exercise and physical activity can have a very strong preventative effect on the development of physiological aging and risk factors for chronic disease. And in most cases, exercise is also very beneficial for the treatment of chronic diseases in combination with medication. However, I think that physical activity isn't necessarily a way to prevent aging or prevent disease. Rather, I believe that physical activity is a way of dealing with what we come across in our genetic predisposition, and it determines how our risk factors or potential chronic diseases will express themselves throughout our lifespan. So overall, what we've seen in this part of the lecture is that in many cases, physical activity is very effective in comparison to prescription medications in the prevention of disease. We also saw that exercise significantly reduces the risk of cardiovascular disease and type 2 diabetes, which are some of the leading causes of death around the world. Alright, so now we're on to the last part of the lecture, looking at pathway F of the conceptual model of how physical activity across the lifespan is beneficial to health. So pathway F is investigating the influence of physical activity during adulthood on mortality, on death. Now, exercise capacity is known to be an important prognostic factor in patients with cardiovascular disease or many other chronic diseases, but it's uncertain whether exercise predicts mortality equally well among healthy and unhealthy persons. So this figure represents the manner in which exercise or physical activity may influence disease incidence, and then how disease incidence leads to mortality. If we look at the all-cause death rates by cardiorespiratory fitness categories in 13,000 subjects, there's a clear trend that we see in this graph. So the rate of death among men and women was much higher in those with low cardiorespiratory fitness compared to those with high cardiorespiratory fitness. The results from this study indicated that low physical fitness was an important risk factor in both men and women, and higher levels of physical fitness appear to delay all-cause mortality. So this is death from any cause, not just cardiovascular-related deaths. So high levels of fitness appear to delay all-cause mortality primarily due to the lowered rates of cardiovascular disease and cancer, because they are such high leading causes of death. If we look at this study by Myers in 2002, this graph represents the relative risk of death from any cause among subjects with various risk factors who achieved an exercise capacity within 3 different brackets. So we're looking at the risk factors along the x-axis here, the risk factors for death being history of hypertension, chronic obstructive pulmonary disease, which is COPD, very common in smokers, diabetes, smoking, BMI greater than 30, or high level of total cholesterol. And then the 3 different columns represent the fitness level. So the lightest column is the lowest fitness, the middle column is mid fitness, and the darkest column represents the highest fitness group. For subjects with any of these risk factors, the risk of death from any cause increases significantly as exercise capacity decreases. So overall, this graph really shows that exercise capacity is a more powerful predictor of mortality among individuals than other established risk factors for cardiovascular disease. We know that smoking is a major risk factor for cardiovascular disease, but if you smoke and you're fit, you're better off than someone who is smoking and unfit. So overall, this study showed that low exercise capacity was associated with higher all-cause mortality risk. The results also suggest that low exercise capacity has a stronger association with mortality compared to other established risk factors, including smoking, hypertension, diabetes. exercise capacity predicts mortality stronger than activity pattern. So if you're someone who's very active throughout the day but doesn't do much intensity, does not have much of an exercise capacity, you just go on lots of long, slow walks, that doesn't predict mortality well. It's the exercise capacity that does. So how fit you are compared to how much activity you do. How fit you are is the predictor of mortality, not how much you do. The study also showed that an approximate activity increase of 1,000 calories per week is similar to an increase in 1 MET of fitness. And both of these resulted in a mortality benefit of 20%. So if you can increase your activity by 1,000 calories per week, which is quite achievable for most adults, you could see a decrease in mortality by around 20%. Another study more recently in 2012 assessed life expectancy associated with various levels of physical activity according to body mass index. And they estimated the years of life lost for joint categories of physical inactivity and BMI. So what does that mean? Looking at this graph here, we can see along the bottom of the x-axis, we have our BMI categories. So the first group of 3 columns is normal weight BMI, then overweight, then obese class 1 participants, and obese class 2 participants. Along the y-axis is the years of life lost. So our reference point, who we assume is going to be the best combination, is the normal weight people and the normal weight and fit people. So if we look just above where it says normal weight to where it's got the METs now, the 3 categories within that normal weight group are 7.5 plus METs. So that's the fittest group, then the medium fitness, and then the sedentary group, which is the 0. So our reference point is the highly active normal weight people, and you can see there's got a 0 and a reference there. So compared to the highly active normal weight people, moderately active normal weight people can expect to live 2 years less, and normal weight sedentary people can expect to live almost 5 years less. If we look at the overweight now, you can see that overweight but highly active is the same. It's still at 0. Overweight but moderately active is at 1.8 years of life lost. And then overweight and sedentary is at 3.9 years of life lost. When we look at obese class 1, people who are very fit and classed as obese would lose 1.6 years of life compared to those who are normal weight and very fit. Those who are sedentary and obese class 1 would lose 5 years of life compared to the reference point. So which joint category is associated with a shorter life expectancy? Are you better off being a normal weight inactive person or an obese active person? So compared to the obese class 1 active category, the normal weight inactive category was associated with 3.1 fewer years of life. So basically they're saying if you're normal weight and inactive, you've got about the same longevity outcome as someone who is obese class 2 plus highly active. At the extreme, so at the very right hand side of this graph, the obese class 2 plus inactive group was associated with 7.2 fewer years of life than the normal weight active reference group. So what this study found was that obese class 1 plus active participants actually lived longer than normal weight inactive participants. So it's the activity. So the activity actually plays a major role, not just the weight of the person. However, the class 2 obese and active participants did not live longer. I remember when this study actually came out and people were running around saying, yeah, I'm taking the fat and fit approach to life. So they were obese, but they tried to be active and thought that was the best way to increase their longevity. I actually asked you guys this question back in week 1. Which of the following scenarios do you think is associated with a longer life expectancy? And most of you got it wrong. 54% of you said normal weight and sedentary. However, we've just seen that normal weight and sedentary is associated with a 4.7 year decline in life compared to the overweight and moderately active, which was associated with 1.8 years of life lost. So we can see those are the three categories we're comparing there. Out of those three categories I asked you, the normal weight plus sedentary is easily the worst place to be. You want to be active, even if that means by BMI you're slightly overweight. Being active is the key there in longevity, as shown by this study. So what we've seen in this part of the lecture is that exercise capacity is a powerful predictor of mortality, that physical activity above the minimal recommended levels increases longevity, and a lack of physical activity combined with obesity is associated with markedly diminished life expectancy. So there you go. What fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? All right, and that's it for sport and exercise in adulthood.